Oh, hello. My name is Dr. Michael Demur. I'm the director of the Precision Medicine Program at Hogue Hospital in Newport Beach. We have a panel for you today to discuss precision medicine. And joining me are Dr. Sarat Darabi. She's a PhD in molecular biology. And also we have Jeannie Homer, who is the lead in genetic counseling at our institution. So with the slides, please. After our slides, we'll have a time for some questions and answers. So really the whole idea behind precision medicine is that all patients and all cancers are not the same. And so we want to tailor an approach that is personalized and precise to a particular patient. So this is based on the technology derived from the Human Genome Project. Certainly you're all aware of the great growth in home to or direct-to-consumer genetic testing. Next slide. And so certainly this has become quite a bit mainstream with a lot of advertising. So anybody can get their DNA tested if they want. And the results aren't necessarily what we as doctors would find particularly useful, but we like to say it's good sometimes for entertainment value. Next slide. So when we talk about precision medicine, we're applying the technology from the human genome to look at patients' genetics and tumor genomics and the sequencing analytic tools that are available to allow us to identify patients that are at high risk for diseases, including cancer, and then allow us to use that information to identify patients with cancer early when they are at a more treatable stage, and then also to tailor treatments in such a way that we can have more benefit and also less toxicity. Next slide. So the Human Genome Sequencing Project, it was a huge project, but that technology is filtered down to allow it to be used as a clinical tool now. And to do this, we take DNA, which is present in every cell in the body. It could be from your white blood cells circulating in your circulation that's drawn from a blood test, or it can be done from a biopsy or an operative specimen from a patient's tumor. And the human genome is based of 3 billion base pairs or letters, if you will, and this makes up the genetic code. And we can look at either the whole genome or segments of the genome to include all expressed genes, or a filtered set of several hundred genes that we know are related to cancer, or just one particular gene if we want to. In order to do this, we extract the DNA, use a technology called polymerase chain reaction or similar technology to amplify that into many copies, which we can then use analytic tools to discern the genetic code. And once we have that, we can analyze that for its biologic and therapeutic significance. Now, this has become practical because the cost has come down, and also the speed at which it can be done has come down. So, or has increased, sorry. The Human Genome Project cost $3 billion and took years and years. Now we can do it, a human genome, for as little as $1,000, and we get results typically in 2 weeks. So this has greatly eclipsed the progress in computing, where the speed of computing was doubling every 18 months, or something known as Moore's Law. The line in green shows that the cost of sequencing has come down in a manner that exceeds the progress of Moore's Law. So this is a team effort at Hogue. We have a director and me, but we have a team of very expert genetic counselors. We have a fellowship-trained genetics physician, a molecular pathologist, and Dr. Darabi is our clinical variant scientist who helps us analyze the genomic results we see. And this team effort then can help speed the adoption, and improve the care of patients. So what does our team offer? Well, first of all, we run the basics of administering the process of getting the tumors to the labs that do the sequencing or coordinating the genetic testing. There's an education process. This is a brand new technology, so all healthcare providers need to learn how to best apply this, and our team provides support by providing consults. We've held education seminars. We identify treatment options and work through patients' oncologists, for example, to interpret the results of genetic testing, how to best apply it in the most beneficial way for a patient. We offer recommendations for who should get genetic testing and other types of profiling, and identify when a standard of care option isn't best, perhaps clinical trial options that might help the patient. We have monthly molecular tumor boards or tumor conferences where physicians from multiple specialties, oncology, radiology, surgery, pathology, all attend the conference, and we can discuss individual patients and their genomic results. And we also support and present at all the many specialty-specific multi-specialty or multidisciplinary patient care conferences. And we're also involved in supporting research initiatives, both in the role of genomics and genetics in patient care, but also supporting therapeutic clinical trials. So the applications of genomics really break down into two main areas. The one is looking at genetic variations, and the other is somatic. The difference is the genetic mutations are something we call the germline, which is part of every cell in the body. So it starts from when you're just a tiny single cell in the womb of your mother, and then every cell divides from that. So every single cell in the body has the same inherited mutation. This is also something you can then pass on, perhaps to your children. Or somatic or acquired mutations that don't occur in every tissue in the body, but just occur in the tumor. So if, for example, somebody develops, in this case, an example of a breast cancer, just the cancer cells have that mutation. So, and based on this sort of divide between inherited or germline type mutations versus somatic mutations, we kind of break down the field a little bit that way. So next slide. First, we're going to apply both of these studies in terms of our not one approach fits everybody. This understanding of genomics allows us to do what we call precision medicine, using the information we get from the sequencing to specifically offer recommendations for individual patients. And so Jeannie is going to talk to you a little bit about the germline mutations and introduce that to you. Jeannie?
Hi. For the past 25 years, my passion and my expertise has been germline genetics. Despite its name, germline genetics has nothing to do with germs. These are, as Dr. Demur was saying, these are the genes you were born with and the genes you can pass on to your children. Next. What we do in our program is cancer risk assessment, cancer prevention, early detection, and implications for family members. Our team of 3 genetic counselors meet with people who currently have cancer, who have had cancer in the past, people who have a family history of cancer, and people of Eastern European Jewish ancestry. And all these groups may have an increased risk for hereditary cancer. We address these questions. What's my chance of getting cancer? What can I do to prevent it? What can I do to find it early? Should I have genetic testing? What will this do to my insurance? And what will it mean for my children? When it comes to genetic testing, one size definitely does not fit all. There are multitudes of genetic tests and many genetic testing laboratories. And before we meet with a patient, we genetic counselors typically discuss amongst ourselves what we think would be the best laboratory to fit the particular patient's personal and family history of cancer, their ethnic background, and their health insurance. Genetic test results can be very difficult to, excuse me, can you go back a slide, please? Genetic test results can be very difficult to interpret. And in fact, in about half of the cases, we do additional research above and beyond the information that's provided by the genetic test report. We also provide each patient with a detailed summary report along with their family tree. Although it takes us at least an hour to prepare these reports, we think it's important to provide a summary written in plain English for the, this serves as a record that the patient can share with their family and refer to in years to come. Genetic testing may be the most important test that someone ever does in their whole life, and they deserve to have it done correctly by an expert in genetics who realizes how important it is. Let me give you one example of precision medicine in germline genetics. Here's a man with prostate cancer at 55, and his brother was diagnosed with prostate cancer at 50. Although he has no sons, he has two daughters who are in their 20s. And he's heard that possibly prostate cancer and breast cancer can go together in genetics. So he comes and meets with one of our genetic counselors who spends as much time as needed with him. Usually it's about 45 minutes, reviewing the genetics of prostate cancer, his family tree, and options for genetic testing. And he was right that there are a number of genes that are connected to both breast cancer and prostate cancer. They ultimately decide on doing a custom panel of multiple genes because he has some branches of his family that he doesn't have much information about. And he wants the most information he can from this test result. Next slide. As you can see, he was found to have a mutation in the gene called BRCA2, which stands for breast cancer, the second breast cancer gene to be identified. Next. Mutations, or like a typo in the gene, of BRCA2 are associated with breast, ovarian, prostate, pancreatic cancers, and melanoma. Now, his daughters, we know, do not have an increased risk for prostate cancer, but if either of his daughters or both of his daughters inherited this gene mutation, then they have an increased risk for these other cancers. And each daughter has a 50-50 or 1 in 2 chance of having inherited this mutation from their father. Both daughters opt to test to see if they inherited this mutation so they can be proactive in their health. The older daughter, unfortunately, did inherit the mutation. And this means that she has an increased risk for these cancers. But along with that, Hogue provides wonderful programs to medically manage this increased risk. And she will start her breast screening at 25 years old. And if no test has been identified in the next 20 or so years to detect ovarian cancer early, it will be recommended that she has preventive surgery to have her ovaries removed. The younger daughter, who did not inherit the mutation, doesn't mean she'll never get cancer, but she would be at same risk as any other woman and would start her routine mammograms at 40. And there is no expected need that she would need risk-reducing surgery. So again, this is an example of precision medicine, tailoring the medical management of individuals based on their genetic test results.
Thank you for that very nice review. Now, as I said earlier, the non-inherited or the acquired somatic mutations are the ones that occur just in the tumor. And we know that the cancer is a disease of the genes. So when we have a patient with an advanced cancer and we're looking for a better treatment, very often we will do a DNA analysis of the genes in that tumor. So Dr. Darabi is going to walk you through a little bit more about how we manage that here at Hogue.
Thank you. Can we go back to previous slide, please? Hi, everyone, and thank you for joining us today. So it was discussed the two-part of genomic and genetic variation. The genetic germline variation was discussed by Jeannie. My part would be the somatic, the ones that you cannot pass on to the next generation. This is also another example of precision medicine, another example that we talk about one size does not fit all. And here at Hogue, we work closely in a multidisciplinary team to enforce this collaboration to make sure that we taking care of patients. Next slide, please. This slide shows the difference that I was talking about. In the past, when one person had a cancer, the cancer would be in a cancer type by the organ and also by the type of the histological type of the cancer, and they would get similar treatment. But now with advances in the molecular technology and precision medicine, all those patients, even though they have one type of cancer and one subtype of cancer, they can be stratified in different subtypes based on their molecular results. So it could be the treatment, it could be the prognostic factor. So this shows a precision medicine program that will look into molecular a subtype of the tumor and the treatment based on that result. What are the benefits of genomic analysis of cancer? It will secure a diagnosis. Some of those molecular results reveal a diagnosis and confirm a diagnosis. Sometimes it predicts the prognosis. Some patients that they have certain genetic variation in their tumor, they might have a worse prognosis comparing to the other ones. And as we discuss about variations, you hear several words that we interchangeably use. Variation, alteration, mutation, these are all meaning the same. So we as a genetic community would tend to use them a lot. So rearrangements are part of the mutation. So it will, another part of that genomic will help is indication of the treatment. This is really important. When one patient has a lung cancer, for example, with a rearrangement or a mutation or change in a gene called ALK, it might have a targeted treatment with crizotinib versus another patient with a lung cancer that doesn't have this rearrangement. They don't respond to this treatment. It also predicts if the treatment would be resistant. For example, certain kind of mutation and variation in EGFR might be indication of resistant to certain type of therapy and to direct the oncologist to change the treatment. Or if there is a mutation in another gene called KRAS in colon cancer might be indication of resistant to another therapy. So when the cost of the analysis reduces, it will help to reduce the cost of the treatment as well. So also some studies that they did meta-analysis, they showed improved survival with a decreased cost of the treatment for cancer. Here's another example of a targetable mutation in lung cancer. We bring lung cancer as most studied, and this is called a pie chart and shows different genes and different mutation found in the lung cancer. So all this little pies you see here, KRAS, EGFR, BRAF with the different percentages shows the different percentages that is seen in this cancer type. These are all indication of either resistant to a treatment or respond to a targeted therapy, or sometimes prognostic factors, and some of them are not approved treatment available for them. It would be an indication for a research clinical trial. So a lot of these, like for example, if recently MET splice mutation was approved for lung cancer with this specific mutation in the gene called MET. So this is really important. This is evolving. However, we don't have always all the information that we hope for, but this is evolving as we go more and we sequence more tumors, we'll learn more, and we're hoping that we're getting more of this targetable treatments for our patients. Recommendations: who would be benefit from profiling the genome? So meaning that when the tumor is collected in the lab and pathology, it will send to a laboratory that they profile that sample and find out if certain mutations are found. So all cancers that are advanced are eligible. Cancers of unknown primary site cancers are referred to cancers that are advanced, that they don't know the origin of organ of the tumor. Rare cancers are another one, or sometimes the cancers that they don't respond to standard therapies. They would be some of the indications for genomic profiling. So all this profiling here at Hogue are sent out, and we, as a team, we review all those reports, and we discuss that in a multidisciplinary case conferences, as it was mentioned by Dr. Dumore. Back to Dr. Dumore.
Yeah, so I think it's important to understand that this is a rapidly advancing field. So the number of genes that we know about or that we understand are increasing. We don't have drugs that target all the mutations, but the pace of drug development is increasing. Drugs are being approved at an increasingly fast pace by the FDA, particularly drugs that target known mutations. To the point now, for example, that Dr. Darabi brought up lung cancer. About 40% of patients with lung cancer have a mutation in a targetable drug. So in many cases, the response rate is better with a targeted drug than the standard chemotherapy, and also associated with less toxicity. So perhaps we can start off with a couple questions that, and I think the easiest or one that comes to mind right away is for Jeannie. Who should get genetic testing? If you're a patient with cancer, how do I know if I should see a genetic counselor?
Honestly, we welcome anyone who's been diagnosed with cancer to come in for genetic counseling, because many times they're concerned about a couple of basic questions. Will I get cancer again? Do I have a hereditary susceptibility that's going to mean I might get cancer again? And might I have something that I could pass on to my children? But those that are probably at higher risk to have hereditary cancer are individuals who were diagnosed at a younger age than usual with that type of cancer. For example, a woman with breast cancer in her 30s or 40s. Those with rare type of cancer, for example, a man with breast cancer. Those who have had cancer more than once. I mentioned before, individuals of Eastern European Jewish ancestry. Those, of course, who have multiple family members with cancer as well, typically the same or related types of cancer. But again, sometimes the people who are the most grateful for the information we provide are people who aren't really at risk, and they're so grateful to know that they aren't because they assumed that they were.
Thank you. Similarly, Dr. Darabi or Sarat, how do you, if I have a patient and I have cancer, how do I avail myself of the precision medicine services at Hogue?
Yes, that's a really good question. So here at Hogue, we have the services to our oncologists. So If a patient is interested, they can discuss that with their treating oncologist. But they need to keep in mind most of the patient's tumor is profiled if they are at Hogue, and then it's all reviewed professionally and discuss that with our oncologist. We directly consult with the oncologist and treating physicians to better care for the patients.
And so I guess in other words is there's no clinical patient comes in to see you, but rather we are a support service and we talk to your oncologist, and then we can review the results with him or her, because obviously the genomics is only a part of the whole picture of the patient, a patient with cancer, but patient may have other medical conditions, being on other drugs. It would greatly impact how we might approach them, and obviously what treatments they've had in the past. I'm going to ask you another question. So what is a mutation? We talked about it, but maybe you can explain in more detail. What is a mutation?
So yes, so as I just touched on a bit, mutation is a change in a sequence of DNA. That can be in the germline, as it was mentioned, that can be passed on to the next generation, that change in the sequence of DNA, or that change can be in the tumor and then cause a tumor. It will be acquired later on in the life, is not in all the cells, it's just in a certain place or organ, and that cannot be passed on to next generation. So that's a somatic mutation or change. So any change in a DNA sequence called mutation. Not all mutations cause disease. We can acquire a lot of mutation in our life, but not everyone's getting cancer. But certain mutation at certain level, they may lead to cancer.
So perhaps I can add a little bit to that. Is the genetic code is just that, really a series of, we say A's, T's, C's, and G's are the genetic code, but the genetic code tells the body what protein to make, and then the proteins are the cells. So if the letters in that code change, you may change the protein, and then the function of the protein is changed. It's either something like a protein that's always turned on, so the cell is continually divided, or you can inactivate a very critical regulatory protein so a cell doesn't stop dividing when it's supposed to, and then acts like a cancer cell. So if we find a mutation, then is that a good thing? I mean, does that, does that mean you can cure me? So, Sarat?
So yes, so if the mutation found in a tumor, that doesn't mean that's a cure. It depends. As we mentioned previously, we are evolving in this field and we are constantly researching in the field to find targetable treatment for the mutation. But any mutation that's found in a tumor doesn't necessarily mean that's the cure. Some of the mutation in some of the cancer types aren't well known, and there are targetable treatments for them, and they're easier to treat, and some of them could be a cure, but not all of the mutations that are found in the tumor means that's the cure. There could be indication for a clinical trial, or could be indication of this is the prognosis factor, but that's not always meaning that's the cure.
Jeannie, let me ask you a question a little bit. So at Hogue, you alluded to there's some great resources that have been developed to support patients that have inherited mutations, if you will, or variants that increase their risk of cancer. So if somebody knows they have an increased risk of cancer based on the testing you do, how can Hogue help them?
As I mentioned, we have wonderful programs that are staffed by physicians who have expertise in not only treating cancer and preventing cancer, but also more specifically hereditary cancer. And they follow national guidelines as well as using their own experience in making sure that the appropriate screenings are done on time for these individuals, and helping out when they might need medications that might prevent cancer or lower the chance of getting cancer, or preventive surgeries. And another wonderful thing about these programs is they don't just treat the body parts, they treat the entire patient. The program, for example, that deals with women who have an increased risk for breast cancer and gynecologic cancer, they also offer consultations at no cost with a dietitian, wellness provider, physical trainer, and social worker, because again, we're treating the whole person and not just the body parts.
So one other thing that comes to mind is people were worried about getting tested because how is this going to affect my ability to get life insurance or health insurance? Can you tell us a little bit more about some of the protections that are available for patients?
Sure. First of all, genetic test results are private and confidential. This is not like one of these direct-to-consumer companies who sell your genetic test results to, or your whole genetic genome to pharmaceutical companies. So there's that protection to begin with. And then there is a federal law called the Genetic Information Non-Discrimination Act, which states that health insurers and employers are not allowed to discriminate against anyone based solely on a gene mutation. In other words, if you were to go out and apply for health insurance, they are not allowed to inquire if you have a gene mutation or a family history of anything, and they cannot use this information to charge you more or to refuse to cover you. With regard to life insurance, that's on a state-by-state basis, and some states, including California, do have protections with regard to life insurance. California even has a law for people applying for mortgages regarding this Genetic Information Non-Discrimination Act. They can't ask you this kind of information when determining your ability to pay back your mortgage.
Well, that's great. This sounds really good, and so, but I'm worried. I mean, it sounds like this is all very high tech and very expensive. And so, tell me a little bit about how much it costs to get genetic testing.
That's a great question, and the answer I would have given you 7 years ago is completely different from the answer I'm giving you today. 7 years ago, I would have said this costs $2,000 per gene, and you may or may not meet your insurance company's criteria. Today, we can say that, as I mentioned earlier, we, as a team of counselors, we work together to find the best test to suit a person's medical insurance. And most of the time, we're able to find a test where the patient pays zero or close to zero for their genetic testing. But if they don't happen to meet insurance criteria, the maximum that any person would have to pay for a full panel of genetic testing is $250. So you can see it's been an amazing change.
That's great progress. And I'm going to ask Sarat similar question. So you have cancer, and of course, you're interested in having your tumor tested. Is that expensive, or is that similarly affordable? Because we know these drugs are very, very expensive sometimes. So maybe there's not much money left. How much does it cost to have your tumor tested?
So yes, for tumor sequencing, most of the insurance companies will cover it. And we have never had issues with coverage with those insurance companies. Some of them, they have maximum out of pocket for the patients with the contract that they have with us. Some of these labs, they don't charge patients over a certain amount out of pocket. But sometimes it might be frustrating for patients because the insurance companies send an explanation of benefit to the patient that is very highly priced, But that doesn't necessarily means the patient, has to pay that when it comes from explanation of benefit. This is just informing them that in the lab charge the insurance company that amount of money. The patients, most of the time, they don't either have nothing or just a few dollars out of pocket based on their insurance.
So typically a patient is not going to pay more than a few $100s at most for their own tumor sequencing. So I think it's been a very fruitful discussion. I think this is the forefront. And if we have this discussion in a year's time, there'll be markedly increased progress. But it's a very exciting time to be a doctor because we have more and more tools available to us to help patients. So I want to thank you for all your attention. But we do have a question, somebody lined up. It says, how to help patients receive pro bono aid? Well, there are very many things that we talk about, and I think we've talked about some of them. The testing from the genetic counseling companies as well as the tumor testing companies, when the testing is done, very often, particularly for patients of limited financial resources, there are programs available where the testing is actually free to the patient. So sometimes you have to apply and make an application. Hogue also has a lot of resources to help patients. So the best thing to do is actually just talk to us and get in touch with the financial counselors at Hogue. And there are a lot of times that we can do things to help on the financial end. Interesting enough, for patients with advanced cancers, when there is a targeted drug, very often we can get the patient either on a clinical trial, and then much of the costs of that trial are then covered by the study sponsor, not the patient. And also, there are times where the companies have, even for standard of care for patients of financial need, great assistance packages because these drugs are very expensive. And then we can get the drugs at little or no cost due to the companies, the pharmaceutical companies themselves having financial aid programs or discounted drug programs. Lastly, for patients with advanced cancers, sometimes we can even get the drugs available on what's called a compassionate use basis, where the company provides a drug free to the patient because the patient has a mutation in their tumor where we think the drug might really help. So we don't want finances to be a barrier to getting care. Anyway, thank you all for your attention today. I hope we've been able to highlight some of the progress and care that we have going on here at Hogue in Newport Beach at our cancer center, and appreciate all your attention today.